It's not easy to understand ventilator functioning, and this requires prolonged experience to use it efficiently. Here in this video, I am just trying to explain briefly basic modes of ventilator and how it works. You have to see this video repeatedly to understand it. Before starting this video, we should know the basic terms used in ventilator functioning. Ventilation, exchange of air between the lungs and the air. Ambient or delivered by a ventilator. In other words, it is the process of moving air in and out of the lungs. Ventilation is measured as minute ventilation in the clinical setting, and it is calculated as minute ventilation is equal to tidal volume multiplied by respiratory rate. Normal is 4 to 6 liters per minute. Oxygenation, interventions that provide greater oxygen supply to the lungs. In a mechanically ventilated patient, this can be achieved by increasing the fraction of inspired oxygen, that is FiO2%, or the positive end expiratory pressure, that is P. FiO2, percentage of oxygen in the air mixture that is delivered to the patient. Tidal volume, volume of air moved in and outside the lungs in each respiratory cycle. Flow, speed in liters per minute at which the ventilator delivers breaths. Peak, the positive pressure that will remain in the airways at the end of the respiratory cycle, that is at the end of exhalation. Peak pressure is the pressure achieved during inspiration when the air is being pushed into the lungs and is measure of airway resistance. Indications for mechanical ventilation. The most common indication for intubation and mechanical ventilation is in cases of acute respiratory failure, either hypoxic or hypercapnic. Other important indications include a decreased level of consciousness with an inability to protect the airway, respiratory distress that failed non-invasive positive pressure ventilation, cases of massive hemoptysis, severe angioedema, or any case of airway compromise such as airway burns, cardiac arrest, and shock. Common elective indications for mechanical ventilation are surgical procedures and neuromuscular disorders. Modes of ventilator. Mode refers to the characteristics of mechanical ventilation, which mainly include trigger, means how inspiration begins. Cycle, how inspiration ends, and limit, when inspiration should be aborted. Ventilator mode is described based on three characteristics: trigger, cycle, and limit. Trigger is the type of signal that initiates the inspiratory phase by the ventilator. Trigger could be patient triggered, that is, patient's inspiratory effort triggers the inspiratory phase by the ventilator. And time triggered means a time interval set by the clinician or operator determines when the ventilator initiates an inspiratory phase. Cycle is the type of signal that ends the inspiratory phase delivered by the ventilator. It could be volume cycled ventilation, means the inspiratory phase ends once a preset volume exits the ventilator. Other types include time cycled ventilation and pressure cycled ventilation. Limit is a value, for example volume or pressure, that should not be exceeded and which is specified by the operator to protect the lung. For example, if we set a tidal volume of 600 liters, machine will limit it to only 600 and not exceed this level. These basic terms, trigger, cycle and limit, are very important to understand all ventilator modes. Now we will move to classification of ventilator modes. There are mainly two types of mode of ventilation: 1. Volume controlled and 2. Pressure controlled. We will see how exactly these mode works. After intubating a patient and connecting to the ventilator, it is time to select the mode of ventilation to be used. If we select to start the patient on volume controlled ventilation, the ventilator will always deliver the same amount of volume and the generated pressure will be dependent on compliance of lung. If compliance is poor, the pressure will be high and barotrauma could ensue. If on the other hand, we decide to start the patient on pressure-controlled ventilation, the ventilator will always deliver the same pressure during the respiratory cycle. However, the tidal volume will depend on lung compliance, and in cases where compliance frequently changes, like in asthma, this will generate unreliable tidal volumes and may cause hypercapnia or hyperventilation. After selecting how the breath is delivered, by pressure or volume, the clinician has to decide which mode of ventilation to use. This means selecting if the ventilator will assist all the patient's breaths, some patients' breaths, or none of them, and also selecting if the ventilator will deliver breaths even if the patient is not breathing on its own. There are many different modes of ventilation that vary minimally between each other. In this video, we will focus on the most common modes of ventilation. Volume-controlled and pressure-controlled ventilation, again classified according to different settings of variable. Common modes of ventilation used are controlled mode of ventilation, commonly called as CMV mode. Assist control mandatory mode of ventilation, that is ACMV mode. Synchronized intermittent mandatory ventilation, that is SIMV mode. Pressure control and pressure support ventilation, that is PCV and PSV mode. Continuous positive airway pressure ventilation, that is CPAP mode. Now, what exactly control mode and support mode or combination of both mode we will see. Controlled ventilation, commonly used in critically ill patients with a significantly suppressed or absent respiratory drive. All spontaneous patient breaths sensed by the ventilator are assisted with a preset volume, or less commonly preset pressure, specified by the clinician or operator. Example, CMV, ACMV and PCV modes. Support or spontaneous mode of ventilation. This mode is used after significant improvement of the critical state in patients who are able to breathe spontaneously and are being considered for weaning. These modes are patient-triggered and flow-cycled. For example, pressure support mode and CPAP mode. Combined, that is simultaneous use of both control and support mode. This is commonly used in patients for maintenance on ventilation and weaning. A preset number, not all, of patient breaths are assisted by the ventilator. Number of assisted breaths per minute is fixed by the operator. Other patient breaths remain unassisted. Volume to be delivered is also fixed by operator. End of inspiration once fixed volume is delivered. Example, SIMV mode with volume or pressure control. Control mandatory ventilation. In this mode, ventilator is set to deliver fixed breath rate and volume. Spontaneous respiration is abolished with deep sedation or neuromuscular blocking drugs. In CMV mode, all breaths are mandatory and delivered by ventilator at fixed time interval, and fixed set tidal volume is delivered by ventilator. Assist control mode ventilation. In this mode, inspiration is initiated by patient, or if not by patient within specified time period, it is initiated by ventilator. In ACMV mode, once patient initiated the breath, the ventilator takes over the work of breathing. It is patient triggered. If patient's inspiratory effort is sensed, all inspiratory efforts are assisted by the ventilator. It is time triggered. If patient's inspiratory effort is not sensed, ventilator delivers a preset number of mandatory breaths per minute. Every breath is delivered, whether initiated by patient or ventilator. Specified tidal volume, set by operator, is delivered. It ensures backup minute ventilation in the absence of an intact respiratory drive and allows the synchronization of the ventilatory cycle with patient's respiratory efforts. For example, if an intubated patient has 4 spontaneous breaths per minute, while the ventilator is set to 12 breaths per minute. On the ACMV mode, the ventilator assists the patient's 4 breaths and add 8 more breaths per minute to reach the minimum number set by the operator. If the patient's spontaneous breaths equal or exceed the minimum number of 12 per minute, the ventilator assists all patient breaths without adding any further breaths. When ACMV mode used in patient with tachypnea due to Non-respiratory or non-metabolic factors, such as anxiety, pain or airway irritation, respiratory alkalemia develops, which can trigger myoclonus or seizures. Synchronized intermittent mandatory ventilation. SIMV mode. SIMV mode is same as ACMV mode, only respiratory rate is fixed by operator, so that beyond set respiratory rate, patient respiratory efforts are unassisted. SIMV mode is volume cycled, means inspiratory phase ends when a preset volume delivered by the ventilator. Inspiratory volume is an independent variable because it is set by the operator and does not vary between breaths. Patient is allowed to breathe spontaneously, that is, without ventilator assist between delivered ventilatory breath. And mandatory breaths are delivered in synchrony with patient's inspiratory efforts. SIMV mode allows patient with intact respiratory drive to exercise inspiratory muscle between assisted breath, making it useful for both supporting and weaning intubated patient. For example, a patient has 20 spontaneous breaths while intubated, and the ventilator frequency is set to 12 breaths per minute. On the SIMV mode, the ventilator delivers each of the 12 mandatory breaths in a synchronized fashion when the patient initiates a spontaneous breath. Therefore, out of the patient's total 20 spontaneous breaths per minute, 12 are assisted by the ventilator and 8 remain unassisted. The total number of breaths remains 20 per minute. Pressure control ventilation, PCV mode. Less commonly used mode of ventilation, appropriate when control of peak airway pressures is important, such as in patients with previous barotrauma or after thoracic surgery. It is time-triggered, time-cycled, and pressure-limited mode of ventilation. Inspiratory pressure is an independent variable because it is set by the operator and does not vary between breaths. Inspiratory volume is a dependent variable because it is not set by the operator and varies between. This graph will help you to understand PSV mode. Pressure support ventilation is used to deliver oxygen and support ventilation in patients with hypoxemic, hypercapnic, and mixed respiratory failure. It is also used to perform a spontaneous breathing trial to determine if an intubated patient on control mode ventilation is whether ready for extubation or not. Continuous positive airway pressure ventilation, CPAP, commonly used to assess the potential for extubation in patients who require little support for ventilation. Provides constant circuit pressure specified by the operator throughout ventilation. CPAP is usually PEEP applied to spontaneously breathing patient. CPAP is a type of positive airway pressure that is used to deliver a set pressure to the airways that is maintained throughout the respiratory cycle during both inspiration and expiration. This is all about common modes of ventilation. Thanks for watching. Please like, subscribe and share the channel.